So the first speaker, I'm really proud to introduce Dr. Holly-NIXON. He's a dedicated registrar in the Department of Surgery. He embarked on his academic journey at Barry University, where he earned a Bachelor of Science in Biology and Medical Laboratory Science. His passion for the medical field led him to a position as a medical technologist at the Princess Margaret Hospital, where he honed his skills and deepened his knowledge. Continuing his pursuit of excellence, Dr. Nixon completed his MBBS at the University of the West Indies, on the Jamaica/Bahamas campus. Along with his exemplary skills as a budding surgeon, he has a clear vision of his future. He aspires to specialize in colorectal surgery, and I think there's a testament to his commitment to advancing medical care and practice in the Bahamas. Recently, Dr. Nixon has taken a significant step towards achieving his goal by enrolling in an elective in colorectal surgery in Alberta, Calgary, Canada. This experience is sure to enrich his expertise, and I'm really happy that he's here to basically show what he's learned. We're all going to benefit from it. And I think it's going to bring him closer to becoming a leader in his field. Please join us in welcoming Dr. Nixon, a future colorectal surgeon in the Department of Surgery. Thank you.
Good evening, everyone. I want to extend a warm thank you to Dr. Lucas, the brainchild for this workshop. Also, the bio that I sent him, I noticed that he added some stuff, but I appreciate it. Thank you. Okay, so today, it's a pleasure for me to do this presentation in terms of a resident perspective with laparoscopic experience and laparoscopic surgery. I just want to reiterate residents' perspective, not an expert. I've had an opportunity to travel to Canada and spend a few months there in colorectal surgery. A lot of their surgeries are done laparoscopically, and I picked up a lot of stuff in terms of overall patient care and safety during the entire process. I have no disclosures. In terms of what I will discuss today, I'll give a little bit of historical background, but I'm sure the presenters throughout today and tomorrow and the various experts, they will cover in detail in terms of the principles of laparoscopic surgery, some advantages and disadvantages, safety issues and skills that can be acquired with laparoscopic surgery, patient preoperative preparation evaluation as well. And also I will discuss just a little bit of my experience at the Foothills Medical Center in Calgary, Alberta. Laparoscopic surgery, when we think about it, it's minimally invasive surgery. So in terms of the term, laparoscopic surgery can be used interchangeably. Okay, so essentially, it's a means of performing major operations through small incisions using miniaturized high-tech imaging system to minimize trauma to the patient and tissue as well. And overall, it is hard evidence that is proven and shows that laparoscopic surgery has better outcomes in the post-operative period for patients that I would mention later on in the presentation. Minimally invasive surgery is a term that was coined by John Wickman. He was essentially dubbed the godfather of robotic surgery. He was a urologist. He did a lot of robotic, really began pioneering the robotic procedures in urology during his time. Just a little bit of history of some of the pivotal physicians in the earlier part of the century that led to laparoscopic surgery and what it is today. For example, in 1901, the first experimental laparoscopy procedure was done by George Kelling. He termed it a cilioscopy. He examined the abdominal cavity in dogs using cystoscopes. Of note, we have individuals like Bertram Berheim. He's a physician at Johns Hopkins. He performed the first laparoscopic surgery in the United States. Also, Philippe Moretz, also he performed the first video laparoscopic cholecystectomy in 1987. Just some of the basic principles of laparoscopic surgery. There's a mnemonic I came across that I thought that basically covered a lot of the basic principle of laparoscopic surgery, which in terms is described as I vitros. So essentially, to perform laparoscopic surgery, there's insufflation of carbon dioxide to create space within the intra-abdominal cavity, to create a working space between the anterior abdominal wall and the underlying visceral and solid organs. Okay, visualization, V. Of course, we have a camera port magnified with light, adequate light source that magnify tissues and structures and important structures that need to be identified during laparoscopic surgery so it can be performed as safe as possible. Also, throughout residency, once we scrub in from day one, placement of your ports, we would hear the terms in terms of port placement and triangulation, okay? And what this does, it helps to optimize efficiency, improve in ergonomics, minimize crowding and clashing of the various instruments that are placed on intracorporeal, okay? R, retraction, manipulation and retraction of tissues. While I was in Canada, one of the main things in terms of tissue dissection, when you compare open to laparoscopic surgery, when you do it open, it's easier to, with the tactile sensation, it's easier to retract, apply tension so you could create the proper and the proper tissue planes, okay? With laparoscopic surgery, it's a bit more difficult, but it comes with volume and to acquire the skills, but basically the similar principle apply that you would require tissue retraction so you could get into the correct planes. And when you get into correct planes, what it does, it helps you to avoid unnecessary bleeding. Usually if you're in the correct plane, you will be, essentially correct planes are bloodless. There are essentially no vessels in that area, and that indicate that you're in the correct planes. O, operate. You choose your incision site, whether it's umbilicals, port entry via the open Hassan technique, which I'm sure the rest of the presenters will cover. Suturing, intracorporeal suturing is another skill that will be required during laparoscopic surgery, and this comes with volume as well, and anastomosis. Also hemostasis as well. Okay, in terms of advantages in laparoscopic surgery, it's well known among myself, the rest of the residents, and all the experts. It decreases the wound size. It offers better cosmesis. Patient satisfaction is attained. In terms of improving visualization, like I said, the camera port it magnifies tissue structures so that you can be able to identify important structures during your dissection. It decreases heat loss from the body, reduces wound infection, dehiscence and bleeding, and also herniation with a larger incision on the abdominal wall. Less postoperative pain, shorter hospital stay during the postoperative period as well, and allow the patient to mobilize early. There are less pain, so they're able to get up, get out of bed, mobilize early, and get out of the hospital. And overall, this helps in terms of consuming resources and in terms of the hospital budget as well. Some of the disadvantages is reliance on a hand-eye coordination, and essentially all of this will have to come with volume. That's one of the take-home messages I would have for the residents in terms of residents' perspective. Try to get in a lot of laparoscopic procedures, pay attention how things are done, and all the safety checks, etc., and try to get as much practice as possible in terms of the simulators that we have set up etc. Also, essentially, some tissues in terms of extraction can be large, so the initial port sites may have to be, incisions will have to be enlarged to remove the tissue, okay? Um, and of course, like I mentioned, it's different from open procedures where you're able to have the tissue, you could feel the tissue in your hand, tactile. In particular, in terms of colorectal surgery, when we're doing hemicolectomies for colorectal cancer, there are cases where, patients have a lesion in the colon, and during pre-op colonoscopy, ideally, the bowel is tattooed. So during the laparoscopic procedure, you'll be able to identify and have an idea of the region where the tumor is located. Okay? So all of that comes in play. And of course, expertise and training is required. And like I said, it comes with volume, lots of volume, and good mentorship and guidance as well. In terms of preparation for laparoscopic surgery, what I've learned, and this is from day one, medical school, up to at this level, for any procedure, whether it's open or laparoscopic surgery, the safety of the procedure starts all the way from the beginning in terms of pre-op evaluation of the patient. Okay, you want to ensure that the patient overall fitness by taking history, physical examination. And these patients can tolerate a pneumoperitoneum, which when we insufflate carbon dioxide, they may have underlying cardiopulmonary disease that may be relative or absolute contraindication to creating a pneumoperitoneum on table for these patients. You also want to find out whether this patient had previous abdominal surgery, because depending on, obviously there will be some level of adhesions. It can make the procedure a bit difficult in terms of laparoscopic. In some cases, when you go in, you may have to perform adhesiolysis prior to actually performing the laparoscopic procedure itself. Essentially, patient blood work profile, bleeding disorders, etc., and informed consent. Okay. In terms of my experience at the Foothills Medical Center, I went over there in January 2010, this year. Straight off the back, it was a shell shock for me. 2024, sorry. Yeah. I was making sure you guys was paying attention. I think Shay picked up on it first. So it was immediately I was met with minus 40-degree weather. All right, so I was almost ready to come back, but I said I'll have to truck on and push on. Okay, essentially my daily task on the service, I was on the colorectal service with the program director of colorectal surgery and various other expertise in colorectal surgery. I had to manage the patients that were on the colorectal. My day would start at 5 a.m. I would get up 5 a.m., go to the hospital, battle the cold weather, see all the patients prior to OR, okay? I would then have to go in the waiting area in the OR section, take history, physical examination of the patient, because usually these patients are already evaluated outside to where their healthcare system is set up, and they're already optimized. I would then have to, acquaint myself, introduce myself to these patients, review the biopsies, any pathology, any imaging, colonoscopies prior to surgery, and then I would discuss it with the attending. The culture over there is, you have to do this as a resident or you won't be able to cut. Okay, so I had to ensure that I saw every patient prior to surgery so I can have an understanding, and then they would allow me to perform some of the surgery under supervision as well. In terms of the OR flow, safety is big. Safety is one of the biggest things. In terms of while the patient is on table awake, there's a briefing that is done in terms of the indication of the surgery, any allergies, etc. All instrumentation that is required, and the patient positioning for the procedures is made known to the OR staff as well. Okay, in terms of whether the patient may be in a Lloyd Davies position or the lithotomy position, supine, prone, or lateral position. Antibiotics are given and DVT prophylaxis as well. And then after the patient is anesthetized, a timeout is done again. And after the procedure, a post-op briefing is done. What was done, what any deviation, any complication from the procedure, what pathology or what specimens was resected, etc. Okay. Now, in terms of, like I said, safety is key. In terms of laparoscopic surgery, you require adequate insufflation, proper port size and site placement. If the patient had prior surgery, they may have some adhesions in the abdomen, would require adhesiolysis before the actual dissection. Positioning as well, in terms of gravity, assist with mobilizing the small bowel. When we do lower anterior resection or right hemicolectomies, patient would tend to be like in a Trendelenburg with their head down. It helps with their head down and table rotated towards whether it's right or left. And this helps with gravity, and small bowel is removed away so that you could be able to perform your dissection without injuring the small bowel. Other features that safety checkpoints that I noted as well is that in terms of, for example, the lower anterior section, once we start our resection from a medial approach, we dissect the mesentery along the sacrum promontory. We first want to identify the ureter, the gonadal vessels, before we proceed with any transection. And we want to ensure adequate mobilization of the colon, whatever we are transecting. And of course, you want to look around prior to any dissection to indicate whether to see if the patient has metastatic disease in the liver or peritoneal deposits. Okay. Laparoscopic surgery, once you go in, has been shown to change the original plan of the surgery up to 30% of the time, in terms of what pre-op imaging had not picked up at the time. Like I mentioned, finding the correct tissue plane is very important, and this comes with positioning of the patient, traction, counter-traction as well. There is a term that they call a O sign. Basically, it kind of tells you that you're in the wrong tissue plane whenever you see you're dissecting, and then there's a creation of a oval sign into fascias. It indicates that you may be in the wrong plane, or if you start to notice that you're having a lot of bleeding, you may not be in the correct plane as well. Like I said, the key thing that I got from all of this and my experience is volume. Volume, I must admit here at PMH, the volume is not as much when I compared it to when I went over there. But in able to acquire these various laparoscopic skills from a resident perspective, volume is key. And you have to start early. You know, residents from second year, they do all the lap appendix under supervision, and third year residents, they would then move on to laparoscopic cholecystectomies as well. And then fourth and fifth years, they'll get involved in more of the advanced procedures like colon resection, etc. When I was over there, I actually performed 15 lap choles in about a month. I haven't done that. I've never done that since I was here, I'll be honest. Okay. In terms of lap appendix, they didn't allow me really to do it because lap appendix were like a year or two residents that usually did lap appendix, and I would do lap choles, etc. In terms of laparoscopic colon resection, which is a more advanced procedure, the attendee would actually do the resection, and then they would allow me under supervision to mobilize the bowel before dissection. Okay, just to summarize, take-home message, volume is the only way to become proficient and confident. The use of laparoscopic stimulators, which is Dr. Lucas has taken on this initiative. Hopefully this may be an annual thing that we can do. Workshop like today, enrollment in courses with high volume centers, and elective opportunities for the residents as well. Okay, and that is my talk for today. Thank you very much.
Thank you, Nixon. That was an excellent presentation. And I think, as Dr. Nixon stated, we need to get the residents from first year comfortable with laparoscopic work and the experience. And that's one of the reasons we thought this workshop was so vital and important. We can't wait, as years gone by, until you're in fourth or fifth year and you're starting to do lap colis and stuff. We need to get those skills from the beginning. My own personal experience, when I did my fellowship, I actually had a general surgery resident. She was second year, rotating through our service. And she always walked with her laparoscopic trainer. And one day I just watched her, practice. And it was amazing to see. I think she had the most dexterity I've ever seen in a laparoscopic surgeon. And as experienced surgeons, she was that skilled. She participated in competitions to fine-tune her skills. And I think it's something that we hopefully can replicate. I don't think that our residents should be left behind. I think they can be at the forefront of laparoscopic work, and we just need to push them there. Without further ado, I talk too much. We are delighted to have Dr. Varunda and our gynecological colleagues. I hope I don't mispronounce your name. Dr. Varunda Shahakar is a seasoned obstetrician and gynecologist with over 30 years of experience, who has been serving the Bahamian population for the past 24 years with dedication. Dr. Varunda's academic journey began in India, where she obtained both her graduate and postgraduate degrees. She further expanded her knowledge by earning a master's degree in public health. She's a strong advocate for holistic approach to women's health. She has substantial experience in managing complicated pregnancies and other gynecological procedures. Her special interests lie in minimally invasive surgeries, and this may include hysteroscopy, laparoscopy, and she also has interest in infertility. She holds a bachelor's certificate in minimally invasive surgery from the International Society of Gynecological Endoscopy. And she's also a full-time faculty member at the University of the West Indies School of Clinical Medicine and Research, where she's involved in undergraduate and postgraduate teaching and mentoring. She also serves as a consultant at the Princess Margaret Hospital and the department chair at Doctors Hospital. She is an active member of several professional bodies, both regionally and internationally. Outside of her professional life, Dr. Varunda is a proud mother of 2 adult sons. She enjoys singing, cycling, sewing, knitting, and any hands-on activity. So I hope you're free for a hands-on session. Give me a big round of applause for Dr. Varunda. Thank you for being here.
So today, a greater detail has been explained by Dr. Holly, Nixon, and Emmanuel. I just came to know his name is Emmanuel also just 2 days ago. So even though my topic is like a basic laparoscopy setup in gynecology per se, for all practical purpose, laparoscopy setup is the same for general surgery as well as gynae surgery. Surgical principle remain the same. The safety issue remain the same. The only advantage we gynecologists have that we have an extra hole. Okay, so minimal invasive surgery actually start with vaginal hysterectomy. So, but we are not really dealing with that today. Holly said all of that. Why patient-friendly, cost-effective, definitely cost-effective once we get all those things sorted out. Less complication, quicker recovery, and that is the way to go with. Every single thing, whatever we could do by minimally access surgery, we should be doing. That is, that's the way to go. So in gynecology, let's say, almost all, at least 70% of gynecological surgery, definitely we can't do cesarean section by minimal invasive surgery. We didn't reach there. So, but everything else can be done laparoscopically in gynecology. All the way from the hysterectomies to smaller procedures to fertility sparing surgeries. Very extensive surgeries they are done by what we call is DIE, like deep infiltrative endometriosis and all of that. They go hand in hand with colorectal surgeons. So all of that. The one little controversial thing came somewhere around 2018, and that was a LAC trial, and Dr. Halliday is sitting right there, and this was like a bummer, because we always say like, laparoscopy, good, 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 but they came with a huge meta-analysis and pool of data and came to the conclusion that the open surgery is better for cervical cancer. Because the recurrence rate and the complication rate, even the survival rate was better in open surgery, and now it is being debated. There's a great guy in India, his name is Shailesh Puntambekar, long name, but he is a gynecological oncologist, and he challenged the LAC trial, and he is a proponent of let me do it, and probably he's doing it for a couple years now, and soon his things will come out. Now there are various theories why probably it is like that. Maybe the most important thing in laparoscopic surgery is surgeon skill, and I think that is the big roadblock for anybody, for resident, for resident to the bosses, because you have a great open surgeon and his skill is so beautiful, like a violin player, but when he go in the laparoscopy he feels so embarrassed, and because you are naked there, because everybody is looking at you, and you can't tie a knot, your instruments go in all different direction, you are hitting whatever, so it is embarrassed. So many a times that is the main reason, that's what I think is the main reason, and that's what I say, basic setup, surgeon setup, attitude. Yes, I can do it. Okay? Once that first hurdle is up, then you can train yourself. Definitely practice and training is really, really important in laparoscopic surgery. Because when you are in open surgery, it's only you and your assistant and your instrument. In laparoscopic surgery, there are so many moving parts, and everything need to be fit in a nice synchrony. It's always like it's an OR theater or OR atmosphere in laparoscopy surgery is very sacred. Either it is like a philanthropic orchestra, or you could say it's nice mass in a church, or that sort of example I want to give, because everything needs to move in a right direction, and you have to have positive energy when you are doing any laparoscopic surgery. Trust me, everybody who work in the OR, they know what I'm saying. You are in OR, you are operating, that one person walk in, and you say, my day is bad. We all know who that person is, and we all know how that happened. Okay? So I just gonna, the next one. So I don't really have that many slides, but I just wanted to break it up, like what OR setup, instrumentation. There may be little bit of repetition, but what Holly was saying, that will happen. This is, yeah, so this slides just show how, and more or less we do have, and I just want us, whosoever are in PMH, to realize what we have. Actually, our setup is way better than so many different places. And when we keep complaining that I don't have this and I don't have this, people need to go other places and try and see what they have. And they're still doing laparoscopic surgeries. And I'm not joking, because in my earlier days, we used to do laparoscopic tubal ligation. There was no gas. We used to use air, just ambu bag. No anesthesia, local anesthesia. Patient in stripped and position. So you're just seeing the uterus up there. But obviously that is really, really basic thing. But what I'm trying to say, once you have access to the peritoneal cavity, things can be done. We did not use any energy. They were just lap band, just put a rubber band on the tube and that's it. You put a rubber band here, you come out. And the instrument what we had was, it is called laprocator. So you have the 10 millimeter instrument with an operating channel through it. So you make one incision in the belly button and you are done. Okay, so that's the OR setup, which is basic OR setup. Like you have assistant and a surgeon. Most of us are right-handed person, so we will stand on the left-hand side. But it is not really mandatory. If you are somebody who is ambidextrous, or somebody can operate better on the right-hand side, they can operate on right-hand side. But most right-handed person would feel better if they stand on left of the patient. We usually have, as I was telling, we have an extra entry point, and that help us in doing pelvic surgery. Because once you put uterine manipulator, you should be able to move the uterus this way or that way. Even if we are not planning, we still try and put the patient in lithotomy position, just in case if the need arise. It is better to have access to the cervix and uterine cavity, and you can manipulate. You have to have ideally 3 monitors, but can you work with 1 monitor? Is it possible? Yes, it is possible. The only thing what you will have to do is your monitor has to be at the tail end, that means in between the legs, so that your surgeon and assistant both can look at it. We have plenty monitors in our OR, 1, 2, 3, and the big monitor on the side. Unfortunately, all of them don't work. Okay. But we make them work. We bought a long cord in gynae department, and the cord go from this side all the way to that side, and it's a weird setup, but it works. So this is the circulating nurse, and it's a standard. The only thing what you try and avoid is you don't want to have too many wires running on the ground. And so somebody can come and trip and fall, and then that should be the problem. So try and do that. Try and keep the same setup all the time, so you kind of develop your muscle memory, you could say. And then the time will, as Ali was saying, more you do, the time will reduce. So this is the same other picture that was little detailed. This is very basic. That's what you will have: assistant and your surgeon, and you have 2 monitors on the side, and that can work. Now, patient positioning, we always do the lithotomy position. I say, but this is a low lithotomy position. Patient is straight and the legs at the low level. This is very, very different than the lithotomy position, high lithotomy position, which we do for vaginal hysterectomy. In vaginal hysterectomy, the legs have to be all the way up like that. Okay? So that you have enough space for the vaginal surgeon to move around. But that is not the aim for laparoscopic surgery. So we do the low lithotomy position. You yellowfin or similar kind of, definitely candy cane we cannot use. Anybody have seen candy cane? Okay? Candy cane stirrups, no, they are not really good for laparoscopy, but at least in our theater, we have yellow fin and the other red fin, but they are the similar. I don't know their name is red fin, but they are red, and one is yellow. So you have the boots, and make sure you pay attention to every single small detail. That is important. So your patient leg position, whether the angle, and it is not really very difficult, just pay attention to the both side and make sure the marker is similar on both sides. Hand supposed to be on the side, and this is the reason why, because you are, at least in gynecological surgery, you are looking all the way down in the pelvis. So your angle supposed to be, your hands are supposed to be ergonomical, because if you hand down here, you're going to keep pushing the patient's hand on the side, and then the patient injury, brachial plexus injury, and all those kind of things happen. So it is always better to have hands on side. Saying hands on a side, that is also not free from complication. It's my own complication, I remember. The patient's hand got stuck between the pole and the hard, even though it was probably wrapped. And I was so scared, I thought the patient developed compartment syndrome. And how I realized that what was the reason, I just went back and thought about it. Why did that happen? Why did that happen? That happened because the leg position was changed in between the surgery. Like I started in certain way, and then the the leg position was moved. So when the leg position was moved, we didn't pay attention if the hand fell down. And that's the time when that happens. So you have to pay attention to those smaller things. So this is this nice video I found, and that is for patient position. So this particular arrangement, if you see, it doesn't really take anything more than 5 minutes. And they are showing. So it's the most important thing what you have seen in this particular video is the accurate kind of device which stop the patient from falling back. Shoulder braces are there, but they are not really advised. Specifically, if we are doing hysterectomy, myomectomy, deep endometriosis surgery, the surgeries are longer, and definitely in robotic surgery, even longer. So steep Trendelenburg is required, and that's why, if you see here, it's playing still? Yeah. Mm-hmm. Right. So you pay attention that both the markers are at the right place. You do not really have excessive abduction. See, the hands are, so this is the position. Pay attention how those hands are, and that's what happened to my patient. Even though it was nicely wrapped, it got tucked, caught between the solid bar and an edge of the table, and the patient developed the injury. So you can take out the accurate, and then now, so this is a very, very simple technique, and we can actually use it. So the bed sheet actually is being used to wrap it. I'll probably fast forward it. And that all goes inside. On both sides. So now, as I was telling, we right. So they are trying to show the slippage. So they put a marker by her head, and in spite of doing that steep Trendelenburg, there is no descent, or you could say there is no slippage of the patient underneath. Because it is important, at least for gynecological surgery, because if the patient slip down, and then if I want to put a speculum, then the table come in between, I cannot put the speculum. Okay. So now a little bit of ergonomics. Hand position. Many, especially all surgeons are tall, but people like me, we are short, and then if I want to do, I will be operating like this. And you just know that it's just not a right position. So the angle should be at least between minimum 90, the forearm, and a bit better, maybe a little more than like 120 to 130 is a better arm position. Monitor, we in our institution, we don't really have monitor height. We need to be little lower than that. We usually look like that. Okay, and that is very important, that surgeons are going to be, and that is actually necessary for both. So it is all the person like me, I always ask for platform. The smaller one, I always have problem because it is a small platform, and if I want my cautery control, then I have to literally be standing on the edge. And the other thing which I realized, that because I'm short, and if I'm doing longer surgery, I lock my knee. And I have to learn how to not lock my knee. And then when the surgery finishes, I type with that I have no legs. So instrumentation, all the instrument, we have good instruments in our institution. So I will suggest all the residents take an initiative when the surgery finish, go to the tray, open and close. Don't break, please. don't break them. Okay, they all are click line. We have stars, and they all click line, and the name suggests click line. That means once you put the inner insert in a right way, it create a click. So that is safety, and that is telling you that you are doing right thing too. So make sure you play with those instruments. We have all different kind of entry instruments. What we have is we have many disposables now. We have screwing trocar also. So that means the screwing trocar has just outer sleeve and a screwing thing. So you can put your telescope into that and then keep going. We have optical trocar also. So which is a clear tip in the tip, and then as you are going in, you could see which layer you are entering. We have old-fashioned stars, which has a flip valve kind of trocar. So it has 3 components: outer component, the middle piece, and the top piece. The middle piece, when you press the button, it opens like a door. The only disadvantage is that you cannot really do suturing properly to that. Or if you are trying to take out a specimen, it's difficult to take out specimen from that. Or you will have to just take the middle piece out and then take out the specimen. The all disposable one, they are radial, so you can take out the specimen from that little better. We have 5 millimeter and we have 6 millimeter also. So 5 millimeters are really nice and sleek, but they are so sleek that they keep going up and down. So the 6 millimeters are better because they have ridges around. So once you put at certain level, they don't have that high tendency to go up and down. 6 millimeter has don't have too many components, and that is better. That's also from stars, and it just has a smaller a rubbery obturator, and that can work well. So if I'm using that, I actually like the 6 millimeter better than 5 millimeter, but you can use either of them. Hand instruments, graspers, scissors, you have to pay attention to the handle. You have ratcheted handles and you have non-ratcheted handles. So make sure you never put ratcheted handle on your toothed, like a tenaculum and scissors. You don't want ratchet on that. Okay, you want that to be free. But if you have a grasper, like a cincture kind of thing, then you could put the ratcheted handle, and they are interchangeable, most of them. Scissors, blunt dissector, suction irrigation. We have an old-fashioned one. We don't really have fancy that wand which come with a dissector also. So you can use it to dissect as well as suck and irrigate at the same time. I'm sure that is pretty expensive. But the simple one, which is a forward is sucking and backward is irrigation, that work too. No problem. The suction irrigator tip can be used for blood dissection. Special instrument, needle holder, knot pushers, staplers, clip applicators, depending upon what surgery you are doing, you will be use them. The very typical gynae instrument is Shadona's knife, and that is to debulk a specimen inside the abdominal cavity. So it's a 10 millimeter hollow tube which has a number 11 adapter. So you can put the number 11 blade, and then or there are some other available too. They call it endo knife, and you can break the specimen. So, and morcellators, we don't have morcellator in our institution. Doctor's Hospital, morcellator gone bad too. Morcellator has a long, big story. GYNAECOLOGY was the best morcellator in the market, but a gynecologist did a surgery on a fibroid. She is a wife of a cardiovascular surgeon. She herself was an anesthetist, and the cancer spread, and the whole thing went on, and the GYNAECOLOGY is out in the market. It's off. The Ethicon and Ethicon had to drop that. So, but what the long story short, you have to pay attention. Now, the incidence of sarcoma isn't really that high. Okay, so maybe 1 in 600. Is Holiday there? He will say no, it is more than that. So it's oncologist and general OBGYN, we always will fight. But to make, we learn, in medical science it is always like that. The people make mistake and then they come back and then we rectify. So there are newer techniques how you could morcellate. It is called in-bag morcellation. So you actually put the specimen in the bag and then morsel it. That can be done too. With the smaller fibroids, you still can cut into pieces and take out. We don't have morcellator in our institution. Whenever I have anything little bigger than that, I'll either make the incision little bigger and do, or you could make the incision little bigger and we have those Alexis retractor. I think surgeons call it wound protector. So you can use that and take the specimen out. It is not really impossible to do that. I don't think I have to go through that. Those are all we said already. Energy devices. You could do all of that. And you could do so many things just with monopolar also. Monopolar has been given bad name because you have to have a return electrode. They could be stray. The people have had return electrode burns before. But monopolar is still a very nice energy, and if you use properly, it can be used. So you always have the either needle, or you can have spatula, or you can have hook. Bipolar graspers, we do have in our institution. We always say that we never see it, but we do have Roby from Storch. We don't have Clippinger and Bissingers. Clippinger is almost outdated. Nobody even used that. Bissingers is not really common here. It is a European, it's a German company. And the tips are changeable. So you can have the same handle and you can have a grasper, you can have a flat grasper, you can have a tenaculum, and those things can change. That is the Bissinger. Special, like bipolar shearer, this you will find, if you watch YouTube videos on laparoscopy, you will find it on Indian surgeons. This is an Indian company, Allen, I think that's the name, and they make, this is, you can say, poor man's ligation. So it is a bipolar device, but the edges of the jaw are triangular. So they're almost like this. So if you just hold it together, it coagulate, and if you press little harder, it cut. So it is better for dissection. Obviously, it doesn't really have that much coagulation force, because for coagulation, you will have better NSIL or ligature. We are having ligature now. I think we are spending too much money on that, but we have it, and we kind of repurpose them too. Ligature, remember, this is still a bipolar device. But bipolar energy is used along with the compression, and that's the way how it achieved the sealing. So once the sealing, you can get carried out, and they say, oh, let me just cut and cut, grasp and cut, but you still have to make sure that you coagulate adequately. The company claimed that you can seal vessels up to 7 millimeter. That's NSIL and ligature, both that they have the claim, but we have to be judicious and careful about not just, you usually use it, coagulate 3 places and cut in between. It's almost like if you use 2 ligature and cut in between, it's the same principle. Harmonic scalpel, that's a pretty everywhere. The orange people, they were marketing that, and that's one of the sweet device. Because harmonic is ultrasonic energy, you don't have that much of the spread. It has a drawback though. It is not a very good sealer. And you have to be very careful when you are using harmonic as a sealer. You cannot put the tissue at a stretch. So you have to put the tissue at its normal anatomical position, and then you can use it. It has added benefit because for harmonic, one is a steady blade and one is a vibrating blade. So vibrating blade can be almost used as a scalpel. So specifically for gynecology, in gynecological surgeries, if you want to do the vault opening and things like that, you'll use it. The vault opening and closing is very important in hysterectomy, because if you go in literature, there was a point when vault dehiscence was very common. Not, I shouldn't say common, but pretty, it was almost like, oh, it's likely to happen. And the reason for that is overcoagulation of vaginal vault. Because you don't really see it when you are doing it, but that whatever white portion is, that's a dead tissue. That's going to slough. And if it's slough, they will have vault dehiscence. So using the energy judiciously at vault is important. So that's how, if you have harmonic, that would be better. And what they have now, um, the dissector is better too. So like if you are using ligashure has a little thick jaw. So if you want to do some fine dissection, it is not really that helpful. So you have to use the regular Maryland if you want that. Laser, we don't have laser and plasma, but yeah, they are useful too. But any energy doesn't come without complication. When we are using any energy, we have to, I'm not really going into complication, coupling and direct coupling and indirect and those kind of things. There are plenty literature available into that, but it is understanding of energy is very important whenever we are using the energy in abdominal cavity. So camera, lens, monitor, light cable, gas tubing, all of that, we have pretty good camera. Our camera is real. Our camera is good than private surgical, I can tell you that. Private surgical, you see all different colonies, yellow, blue, whatever, and then you have to look, where is my tissue now? But this camera, what we have in PMH, I'm talking about, I'm not talking about doctors, is a very nice camera. I think this is a 3-chip or 4-chip camera. And then I realized that we have even a better system. It is called Spice. Yeah, I think that's the name. So it is a system where if you put that Clara and Chroma into that, so it gives you enhancement of underlying vasculature. So if you find in literature, especially urologists in bladder cancer and all, they use this particular technology and the underlying pathological structure will be enhanced and you can take biopsy from that. But we have that. I checked in our system, we have that. So that is because that's our eye. You whatever you are saying, that's the only thing you are seeing. In open surgery, you can look at here, there, everywhere, but not in laparoscopy. But because you distend the cavity, on the contrary, you have better vision in laparoscopy. But your vision is still only that. But you definitely have better vision because of the distension. So then, and different telescope. We have 5 millimeter, we have 10 millimeter. Those are 2 standards. We have one which is even, those are for hysteroscope actually and ENT, but standard for laparoscopy usually 5 and 10, and we use 30 millimeter, 30 degree, 0 degree. We don't, 70 degree, only urologists use it, and don't even use 70 degree, you will get dizzy. You just don't know what I'm looking at because the 70 degrees isn't really conducive to general surgeon and gynecologist. But 30 is good because sometimes you have a pathology and you want to look little lower down, so 30 degrees is good. I think we even have a flexible one which you can have a 0 and you can bend the tip. I think we have one. Yeah. So it is 0 degree, and if you it is adjustable. You can actually make from 0 to all the way to 90. I think so. So depending upon, like say for example, you are like I do not really want to make any of my port 10 millimeter. 10 millimeter is my port in the umbilicus. I don't want to increase anything. So then we take a 5 millimeter port, 5 millimeter scope, and put from the next one and take out the specimen from 10 millimeter. I will not make next one 10 millimeter. So it can be done that way. So this is again the setup. All right, I think I'm taking too long. All right. So now in laparoscopic surgery, if you see the number 1 culprit is entry. So major complications would be vascular and bowel injury. And it's 5.7 to 6 per 1,000. That is the standard complication rate is given. And 70% of those occur at the entry. So when you are trying to enter, this is the time, and this is the reason why you have to master the entry technique. You can start from with your varies, you can do whichever, but pick your technique and practice it. Like I graduated from varies. I started with varies. So when you are doing varies, you can use the confirmation. So when the varies needle is in peritoneal, because peritoneal intraperitoneal pressure is less than atmospheric pressure, so that's how. So how R.K. Mishra explained suction, irrigation, and hanging drop. Okay? That means you can push the saline if it goes without resistance. That kind of tell you that you are in a right space. Aspirate again. If nothing come, that tells you that it has gone in a hollow space. And then once you put a drop of saline onto the tip of the Veress needle and it gets sucked in, that is the reconfirmation. That's what it is being shown here. That the saline pushed, then I think it's pulling out now, and then the hanging drop. So it is pushed, so nothing coming out, and then when you leave a drop, make sure when you put the Veress needle, your patient is flat. Please do not put her in Trendelenburg position. And I don't really have here to demonstrate, but once you put in a Trendelenburg, you are coming very closer to the sacral promontory and your bigger vessels are right there. And then and if your patient is thin, yes, you do have a chance to hit the vessel, and that you don't want. So I graduated from here, and I do direct trocar entry. So some people think it's this is what? Veress needle. So this is supraumbilical. Sometimes you have to do supraumbilical depending on why we choose umbilicus. No brainer there, because that's the thinnest portion. All the layers, they come down there, and it is easy. And then naturally there are no adhesions down there unless you have done something before and then the adhesions happen. So that's why it's a sweet spot to enter. But in certain situation, you might have to go supraumbilical. It is just for the sake of, and then you can hear three different clicks. But I always feel that I don't feel comfortable with that. I think you are, because what happens is, if you have seen people, they put the Veress needle and then they do like that. Okay, now if you have already caused some damage, you are even causing more damage. And then because Veress is so small, it can get stuck with little momentum and thing, and then you don't really get pressure. So you are not really very sure whether you are in or not. So I can show you what I do. So this is a lady from San Francisco. Her name is Dr. Kato Hanlon, and I'm a video stalker of her. I just watch her videos, and she explained this direct trocar entry, and it's very sweet, in a sense that you just have to watch. Once she put the towel clip, she bent the abdomen as high as possible. The key of this is using towel clip. Those Ellis, they don't work. Okay? So you try and put something, and then because when you are doing, you are going straight. Okay? If you are using, which kind of trocar you are using, your force of direction also change. If you are using this kind of one disposable, it is almost straight. If you are using the pyramidal tip, which we have, the old-fashioned one, your movement should be screwing movement. Make sure you put especially for the thinner patient, you have to put your hand somewhere in the middle, so you're guarding that. The position of the umbilicus also is important. The bigger the patient, the umbilicus go lower and lower and lower. So you can't really put in 45 degree, you just literally have to go straight. So so she just tend it. See that how she tend? And then, yeah. So that is my preferred technique, but as I was telling you, you can choose. And then the second one I will do probably, if I am in confusion, I'll probably do Hassan is the next best one. Because one is, it's not that the literature says the complications are same in all of them, but as I said, you choose which one you want to do. Sometimes it is difficult to get that. So what happens is it's not shown here. You can pull the umbilical ring either lower down or upper down, depending upon where you want to do, and then use the umbilical ring as your guard for, or as a marker for the rectus sheath. And once you go through rectus sheath, then it should be straight. Problem happen when you try and put the gas prematurely, and then the gas everywhere, and then you can't find plane. That does happen. This is a Palmer point entry. If somebody has a, so it's usually, it's like about like 3 centimeter below the costal line and in the mid clavicular on the left hand side. Make sure your patient doesn't have stomach full. So NG tube should be there, so stomach is deflated, and then you can goodies. There's a other person from India. Her name is Nutan Jain, and she has she's propagating what she she's proposing. This is the point. She call it Jain point. That's her name, Jain, Nutan Jain. So this is the Palmer point, and this is a. You can see my. Yes, okay. So this is a Palmer point, and this is a Nutan Jain point, and it is little lateral, and she said it is almost similar, that there are usually no adhesions in this area, and the advantage of this is you can still use as one of your port, because once you put it, it's a Palmer point, and using any instrument through Palmer point is not really very helpful. So you will only do the entry through that, and then that is not really useful. So this one you can use. For gynecology, we have another added one, that you can actually create pneumoperitoneum through cul-de-sac. So if your patient has upper abdominal surgeries before, and you are not very, but don't feel ashamed, because if I'm uncomfortable, I will ask surgeon to come and give me entry, and then rest I can do, because they are more used to doing Hassan. There isn't really anything that if I can't do, I can't do. There isn't really anything I'm feeling ashamed or anything about that, because eventually all are we here for the patient. What is best for the patient, that's what we have to do. We have to work as a team. All right. So as I say, safety first, know your instrument, know your energy. Be vigilant while operating in peritoneal cavity. Pay attention to your assistant too, and that's the reason I say, I have somewhere, build your team. It's very important how your assistant is, because your assistant could be a disastrous one too, because they are the one, they are looking, you have to tell them, oh, I am the driver, so please show me. I'm not asking you to go around. Yes, that does happen. So it is assistant is very important, and have a plan and anticipate you. It's always important for any surgery, for that matter. It is not really laparoscopic surgery. If you are going to do something, think about it, what else can happen. If I perforated viscous, if I do this, we need to know who is the surgeon on call. Who can I call quickly? I need to know who is the urologist around, right? Where are they? So those kind of things are very important. Have a plan. Not like the other day I called Dawn 2 o'clock in the morning. So those sort of things, it is very important. So we have to, and laparoscopy, that's what I say, laparoscopy is very spiritual, in a sense that, all those big ego and stuff like that, if I can't do, I can't do. And I have to take help. So in summary, as I say, laparoscopy surgery is a very rewarding experience. You feel really great after doing it. Even if your hand, your back ache and your knee ache and everything, you really, really feel good after that. Once your patient next day, she is eating, drinking and walking around, and you're sending her home, that's the best experience, right? So the key to success is practice, practice, practice. Yes, practice, but practice the right way. That is important too. Okay? You can learn a whole lot from the YouTube. You can learn, but you have to pick which YouTube you are watching. Okay? And when you are watching YouTube, there is another way how to learn from YouTube is, have your notepad ready and make note. So say for example, just a simple example of if you were doing to bladder dissection in previous cesarean section or something like that. So there is a technique, they call it as a lateral window. So when you are watching it, a good person from Canada, his name is Dr. Soni Sukhbir Singh, that's a long name. He explained it very, very well. But you have to have your notepad with you and write down what you are watching down there. So even if you finish watching that, 20-minute, 10-minute, 1-hour video. You look at your notes and see, okay, yeah, this is the way he did it. And then you can replicate in your. There's another fancy thing. It's called online mentoring. It didn't really come up, that one. And this is, I think that is the way to go forward, because I come across with, there's a pediatric endoscopic society, and they were doing it. So it is like you have a great surgeon, say, in Canada. Now his fellow Lucas is operating here. Lucas is telling him that this is a complicated case, I want to. So there is a screen sharing, and he can say to Lucas, see this area I'm seeing, probably go on that side. And this is very important. You could do that way. And that I didn't really hear any this thing I heard. There was a conference I heard at maybe like 5-6 years ago, but maybe the legal framework, the jurisdiction, who is liable for if there is a lawsuit or something like that. That's why it kind of went down. But I think that is the way forward. We could actually do that way. All right, so know your practice, but practice the right way. Do not keep doing wrong, and you are still wrong. Always you like say, use your time, millimeter by millimeter. All these big shot people, they say, just pay attention what they say. Do your dissection millimeter by millimeter. Look first, clamp first, and then cut. Do not really do anything blindly. Use CO2 as your marker, because when you use the pneumoperitoneum, that will show you the spaces. If you are putting things and unnecessary things bleeding, there's definitely you are in a wrong plane. Do not go perpendicular to any linear structure. If you are doing any dissection, your dissection to any tubular structure, it has to be parallel to the tube. For us, pay attention to the posterior peritoneum, because the ureter is sitting right there. We don't know which direction it is lurking. So all those kind of things are important. So practice, but practice correctly. Build a team and make sure the safety first. Always safety first. All right, so thank you very much.
I really loved what you talked about in terms of having a good assistant. I remember Dr. Francis had a conference a while back, and I was the assistant, and I can say I was a very terrible assistant. And the professor was cursing throughout the case, and afterwards, I don't know what he said to Dr. Francis, but it was very embarrassing. But the other thing is building strong teams. We have to help each other. We need to learn from each other, and I think leaning on expertise is important.
It is better to take a surgical assistant than your co-surgeon. Why? Because the surgical tech knows that he's not a surgeon. But if you have your colleague, the colleague also, so the colleague is looking for himself. And then that's the problem. But then you have to develop the rapport. But that is very important. Yeah. Mm-hmm. Thank you.
Thank you so much. Thank you. We have next Dr. Don Major, who's a mentor to me, honestly. And he took me on his wing when I came to the Bahamas, and really taught me a lot when it came to surgical skills. He's a distinguished graduate of the University of the West Indies in Augustine. He made history by being the first Bahamian to complete the surgical residency program in UWI Bahamas. His pursuit of excellence led him to the Tom Baker Cancer Center in Calgary, Alberta, where he completed a fellowship in surgical oncology and hepatobiliary surgery. Currently, Dr. Major serves as a consultant surgical oncologist and hepatobiliary surgeon at the Princess Margaret Hospital and other institutions. His commitment to his profession is further demonstrated by his active participation in many, again, regional and international organizations. His journey in medicine has been marked by dedication and a relentless pursuit of knowledge. His contributions to the field continue to make a significant impact on patient care right here in the Bahamas. Really look forward to your continued success in your endeavors. Without further ado, Dr. Major.
So today I'll talk to you a bit about laparoscopy and hepatobiliary. A lot of it is some of the stuff that I've been through already with respect to laparoscopy. I'm going to kind of go through some of the principles, important for patient positioning, port positioning, And some of the common laparoscopic HPB procedures that we do here in the Bahamas. Presently, I have no financial disclosures. So when we look at laparoscopic surgery, we all know that the first lap chole was performed in the US in 1988, or the first documented lap chole. And now almost every organ can be reached via laparoscopy. And 90% of the choles are actually done laparoscopically. So when we look at some of the instruments that Dr. Varunda kind of went through earlier, we have the basic graspers, your shears, your electrocautery, most commonly the L-hook. Sometimes we have the harmonic, depending on where you are. The ligature, we got staples, we got locking clips, suturing devices, and most importantly, in the world of HPB and laparoscopy, the laparoscopic ultrasound. Something that we do not necessarily have here in the Bahamas, actually, because it tends to be a very pricey piece of instrument. So, as also stated before, some of the benefits of laparoscopy: cosmetic. You have a much smaller incision as compared to an 8 or 12 centimeter scar going down the midline, or a cochlear incision. There's way less pain associated with it, quicker recovery time, shorter hospital stay. There's also been shown to have fewer post-op adhesions because we're not manipulating the bowel with our hands, we're using these instruments. There's also fewer wound complications, fewer post-op complications, and then we also are able to get better photos and videos and magnified views of whatever it is that we may be looking at that time. So some of the laparoscopic surgeries that we perform in HPB would be that of the diagnostic laparoscopy, the lap chole, which is the workhorse, laparoscopic liver resections, that could be major or minor liver resections. There's also the laparoscopic common bile duct exploration, and finally the laparoscopic pancreatectomy, which is usually either the distal pancreatectomy plus or minus spleen preservation or splenectomy, and finally the Whipple. Now, for all intents and purposes, I have yet to perform a laparoscopic Whipple. I don't think my senior partner has either performed one. We generally deal with distal pancreatectomies. What is Whipple? Oh, so Whipple is also known as a pancreaticoduodenectomy. So basically, it's when you have pancreatic head tumors, and you take out the head of the pancreas, the first part of the small intestine, a piece of the stomach, the bile duct, gallbladder, and then you reconstruct all of that. Generally, in the open setting, it's anywhere from about 4 to 8 hours. So laparoscopy probably adds an additional 3 to 4 hours on top of that, especially if you're just starting out, right? So some of the requirements for HPB surgery would be, number one, commitment, because these surgeries can be quite complex, and you have to be committed to learning this laparoscopic skill set to say, go ahead and do these. Then you also need to be ideally a trained HPB surgeon, so somebody that's actually trained in these areas and are quite aware of the anatomy of this area and things that can go wrong in order to avoid these pitfalls. It'll be ideal if you also have advanced laparoscopic skills, such as suturing. And there is a learning curve associated with the training. So ideally, you'd want to train at centers that have large experience and have an established technique that you can kind of reproduce. Ideally, you'd like to have a 45-degree camera on a 10-millimeter scope. Presently here, we do have a 30-degree, as well as I think we have a chameleon that's present. Some centers, when I was in Paris for a few weeks, they actually have a 360-degree scope with a flexible tip, which makes major laparoscopic liver resections way easier. But obviously, it's much more challenging working that lens and getting used to that. Patient position is also another key factor in laparoscopic surgery. So it plays a key role in advanced solid organ surgery. You want to position, prep, and drape these patients, taking into account the steps of the operation that you're going to perform. And the thing about laparoscopy is you don't want to necessarily get stuck, because you tend to have multiple ports that you can move the camera into. If you have more than one 10-millimeter port, you can place it at different angles to try and get better visualization of whatever it is that you may be looking at. And finally, the biggest thing is gravity. So you want to use gravity to your advantage because you want to have these patients in steep positions in order to move organs out of the way to give you a better visualization of what's happening. So gravity uses the patient's weight to your advantage, and it's a silent, obedient, and reliable surgical assistant. So just want to kind of go through the LAPCOLY briefly, especially for our residents here. I did record a video. I just wanted to kind of point out a few things, especially for our, so here, oh, kind of went by. So most everybody in the room should know the basic port placement for a LAPCOLY, right? So we have the 10 millimeter port at the umbilicus, 10 millimeter port in the epigastrum, 2 5 millimeter ports in the right upper quadrant. Some people do a 5 millimeter port in the midline, and then another 5 millimeter port in the right upper quadrant. And then you also have the SILS cholecystectomy, where everything is done through the umbilicus, right? So it all depends on your skill set and training. So once in, now we kind of insufflate, we put in all our ports, and we kind of have a general look around in the abdomen just to make sure there's no other pathology going on. And as you can see here, we grasp the fundus of the gallbladder, we dissect off sharply any kind of adhesions that are adherent to the gallbladder, and we want to take that down to the Kalos triangle. Yes, so that is a monopolar or the L-hook device, right? So one of the things that you as residents have to look out for is Rouvier's sulcus, right? Because what are we most afraid of in a LAPCOLY is a bile duct injury, right? So certain things you want to look for to minimize the risk of developing a bile duct injury. One is Rouvier's sulcus. I don't think it shows that well here. Yes, right down there. I don't know if you guys can see. Probably got to come around a bit. Yeah, so this guy here. All right. So you want to make sure that at all times that you are actually above that sulcus when you're dissecting out Kalos triangle in the critical view of safety. One thing that I learned early was that if you cannot identify the cystic duct infundibulum area or junction, then the chances of you getting this gallbladder out successfully laparoscopically is minimized. So that's one of the first things I kind of look for, where the cystic duct joins the gallbladder, and if I could identify that within the first 5 minutes of the operation, then I kind of have a pretty good idea that this should be able to come out as a full gallbladder as compared to some bailout maneuver. And again, they're just kind of dissecting off the adventitia outside the gallbladder and the tissues around it. And I like this approach with respect to the use of the L-hook. Dr. Taylor doesn't like it that much. He always wants me to pull out the Maryland, but I prefer using heat to try and minimize the risk of bleeding, and just go ahead and go into the fatty tissues here. All right. The other thing that I've also noted sometimes you can actually see, you don't necessarily have to look for it to minimize a bile duct injury, is sometimes you can actually see the bile duct going up the portal, depending on the thinness of the patient and depending on the diameter of the bile duct, you may be able to see it, and then you kind of know that, hey, I can safely stay away from that to minimize any evidence of bile duct injury. And here they are just illustrating the critical view of safety, which we would love to have illustrated prior to clipping anything. And you have to kind of fulfill a few factors. You want to see 2 structures and only 2 structures going towards the gallbladder. You want to have all that fibro-fatty tissue within the triangle cleared. And then you also want to have the lower third of the cystic plate actually elevated. And once you've successfully illustrated that, then you know that it's safe to go ahead, clip your duct, clip your artery, and then go ahead and cut. Generally after that, then you just take the gallbladder off, and then you're pretty much good to go. Put it in an endo-catch bag, and then you can take it out. So that is one of the, I guess, common workhorse procedures that we do in general surgery as well as hepatobiliary, right? I know you guys didn't come here for a general surgery talk, so the other thing that we tend to do commonly here, or not necessarily commonly, but another laparoscopic procedure that we do here in the Bahamas would be the left lateral sectionectomy, right? And this is when you have tumors within the segment 2 or 3 of the liver, which tends to be the left lateral segments. and these are on the left side of the falciform ligament, and we tend to do those laparoscopic because of I guess it's a simpler operation. And here we go, another quick video kind of illustrating that. So as you can see here, here's the lesion that they're going after. It's right up against the left hepatic vein. So hence they want to go ahead and do a left lateral sectionectomy. And here we go. So again, the port setup for this one. So generally we go ahead and we do it at the level, a 10 millimeter port at the level of the umbilicus. Then we may have a 10 millimeter port to the left of this, just above the umbilicus and in the midclavicular line. And then we probably have a 5 millimeter port up in the epigastric area and a 5 millimeter port up in the left upper quadrant. These patients tend to be supine with arms out, and the reason for the two 10 millimeter ports, or 10 and a 12, would be one, that you can actually move cameras from the umbilical port to the midclavicular port, and then the other is that you can actually pass a stapler through the 12 millimeter port, because most of this operation is done with energy device, whether it's the ligature or the harmonic. And basically you kind of use the ligature to divide through the parenchyma of the actual liver, and then once you get to the biliary pedicles, you can use a stapler to come across with a vascular load, as well as once you get towards the left hepatic duct or the left hepatic vein, you can also use a stapler. One of the benefits of doing the left lateral sectionectomy, as we're doing here, is that this segment of the liver tends to be quite thin. So this is why you can use an energy device to kind of go through it. And once you, as they're showing here, once they reach the vascular pedicle, they just put in a stapler with a white load or a vascular load, and they come across it. And once that's done, you can place that in an endocatch bag. Generally, you need like a 15 millimeter bag for something this size, and then you can deliver that via the umbilicus, or you can even deliver it via the a fan and seal incision. All right. Again, looking at the port sites, a 10 to 12 at the umbilicus, sometimes that's a 12 millimeter there, and then two 5 millimeter working ports. And some of the pictures that you may see, sometimes when you're going towards the top, you get a visualization of the hepatic veins. And if present, like I said, if you don't have, you'll use the intraoperative ultrasound to identify where the lesion is exactly. And then you can see that you're using a stapler for division of your hepatic vein as well as portal pedicle. The final procedure I just want to kind of briefly touch on would be that of the laparoscopic distal pancreatectomy. And generally for patient positioning, we tend to have them supine, right? And sometimes you just put a bump underneath the left hip to kind of bring them up, right? And that can kind of give you enough exposure to go ahead and do your distal panc. And again, showing trocar placement similar to the left lateral sectionectomy. You have the 10-12 in the midline of the umbilicus, 12 millimeter over to the left, and then 2 5s in the upper abdomen. So this technique that we use is called the Osborne's technique. And I just wanted to show, basically, it's a counterclockwise approach to actually doing a distal pancreatectomy. And what happens is you take down the splenic flexure first, and then you come around and you get into the lesser sac. And then once in the lesser sac, now you elevate the inferior edge of the pancreas where you go behind, and then you now identify the splenic vein, and you ligate it depending on where it is in relation to the tumor. Yeah, that's it. So yeah, once we mobilize the splenic flexure, we come around and we enter the lesser sac and pretty much elevate the pancreas off of the retroperitoneum. And we identify the vein, ligate the vein, and then generally the arteries on the superior aspect. And there's an instrument that we tend to use to encircle the artery. It's a laparoscopic finger. I'll show you a picture of it. And basically, once we encircle the artery and we divide that, then we go ahead and remove the remainder of the pancreas along with the spleen. Now, there are a few ways in which you can preserve the spleen. One way is that of splenic vessel preservation, which basically you dissect out the splenic vein and the splenic artery, and you just ligate the tributaries towards the pancreas, right? Which is obviously a bit more tedious. And then the other way is what we know as the washout technique, which basically you remove a segment of the splenic artery and vein along with the pancreas, and you have to ensure that your epiploic vessels are intact, as well as your short gastrics, because the spleen now will be supplied by your short gastrics. So if by chance you damage your short gastrics, you will lose your spleen. Okay, well, basically that's the end of it. I just kind of wanted to show you guys that finger retractor, which is quite important with respect to distal pints. And in summary, laparoscopy can be used for many procedures related to HPV. It does take intense training and adequate patient volume, and most cases can be performed safely in a low resource setting. Thank you.
Our next presenter, close to my heart, Dr. Irwin White-GITTENS. I see him as a brother in arms because he has the same vision for me as me when it comes to elevating surgical care in the Caribbean. I'll get a little bit into him. Anyway, he's a dedicated and accomplished vascular surgeon, and after extensive journey in a medical training, which began in St. George's University, he honed his skills in general surgery at Harlem Hospital, New York. He then further specialized in surgical critical care, so he's doubly board certified at the University of Minnesota. His passion for endovascular and minimally invasive techniques were again ignited during his time at Staten Island University Hospital. Dr. Irwin White-GITTENS has a particular interest in complex limb salvage and cerebral vascular disease, and that'll be the focus of his talk for the next 2 days. He was able to grace us with his presence via Zoom about a week and a half ago, so I'm looking forward to learning some more about TCAR. He's made a significant impact in Montgomery, Alabama, where he performed the state capital's first TCAR procedure in 2023. His commitment to patient care is evident in his instrumental role in establishing a pulmonary embolism response team, which has significantly improved patient outcomes. And we're hoping that we can create something similar right here in the Princess Margaret Hospital. He's a proud native of Trinidad and Tobago. Dr. Gittens is dedicated to enhancing vascular and endovascular care in his home region. When he's not making strides in the medical field, he enjoys lawn tennis, football, real estate discussions, I don't know why, and chess. We still have to play a game. Again, without further ado, Dr. Irwin White-GITTENS.
Okay. As Charles said, I am from Trinidad, and I spent most of my medical career in the U.S., but my parents live in Trinidad, all my family is there. And I get calls every day, hey, auntie so has this, could she come to you in the U.S.? And there are a lot of limitations. So my goal in life is to improve healthcare in the Caribbean region, and what better place to do it than Bahamas? It was hard convincing my partners that I came here for a conference, but I'm here now. All right, so today I'll be talking about carotid artery disease. This presentation I did 2 weeks ago at the Grand Rounds, so I'll just go through it very quickly. It's a very new procedure, so I feel like I need to give some context. I guess. So yes, so I have no disclosures. This is the agenda of the talk, and essentially carotid artery disease is one of the illnesses that I treat in the US. I have a full complement of vascular disease, but this one in particular I feel very passionate about because it is undergoing a transition over the last 5 years or so. So strokes account for leading cause of death and disability, as we all know. And as of 2020, this is before the pandemic, or I guess along with the pandemic, 7 million people died from strokes. That doesn't account for people that have permanent disability, etc. So of those many strokes, approximately 85% of them are ischemic, meaning it travels from somewhere else and goes to the brain. My focus is specifically of the extracranial carotid arteries, but you can get strokes from other areas, including the aortic arch, patients with AFib. The way I look at this is that we have drugs for atrial fibrillation. We screen people. It's very easy to diagnose these people, but there is a limitation when it comes to carotid artery disease because we're not screening as many patients as we should. So most of my practice is guided by the Society of Vascular Surgery guidelines, and specifically they want you to check for bruits. Not everyone carries a stethoscope, but my practice, I specifically screen anyone that smoked, that had a family history of strokes, and with peripheral arterial disease, coronary artery disease. A quick ultrasound could rule it out, and it's just like screening for abdominal aortic aneurysms. You have one, if it's less than 50%, I rarely ever look again unless they become symptomatic. So we have several options, listening for bruit, but some of the patients that I actually heard bruits on, they were actually negative. They had minimal disease. So it's not as sensitive as SVS suggests. The other way, and this is my workhorse, is duplex ultrasound screening. We have very good sonographers in my office, and they can detect, very minimal disease, and we also follow patients every year, and we can compare ultrasounds, etc. So it's non-invasive, it's relatively cheap, it pays for itself over the years, and it can really follow patients. And this is also a key part of actually doing the TCAR procedure, having some ultrasound skills. And finally, before any procedure, if I'm planning surgery, I get a CT angiogram, but there are some limitations. Not everyone can get a CTA. If you have abnormal kidney function, etc., that can be a limitation. So as we all know, symptoms of stroke, etc., typically I get a lot of referrals for dizziness or bilateral weakness, etc. Those are rarely ever due to carotid artery disease, at least the common and internal carotid artery disease. So once you do an ultrasound, we classically look at the velocities, all right? So when you have blood, which usually flows in a laminar direction through a narrowed vessel, the velocities will increase. And we've looked at hundreds of thousands of specimens and ultrasounds, and we found that once your velocity is over 135 centimeters per second, that typically corresponds with 50 to 69% stenosis in a blood vessel. If it gets higher than that, it corresponds to 70 to 99% stenosis. If you have symptoms and you have above 50% stenosis, we usually intervene. And in 2024, we have several different options to intervene. If the patient is asymptomatic, which is a big part of my practice because everybody's getting ultrasounds now, I have a very individualized discussion with the patients, and I go over treatment options, etc. And we'll go over some data with that. And then I just put this in there to show that last year, the IAC accredited labs actually increased that number from 135 to 180. So we were, treating a lot more people or following a lot more people. And the ultrasound, the consensus criteria was designed in the 1970s using old ultrasound technology. So the newer ultrasound technology, we found that 50 to 69% stenosis correspond to velocities of 180 to 230, unless you have ICA to CCA ratio of greater than 2. That's something I don't think is important for this talk. So carotid artery disease. As I discussed in my Grand Rounds talk, we've had a lot of clinical trials looking specifically at cerebrovascular disease and stroke because it's so prevalent, and it's one of those things. I tell my patients, you can lose a leg and still walk again. If your aneurysm ruptures, you'll probably die. You wouldn't really know any different. But if you get a major stroke, it's a life-altering something. So, and we've made strides in it, but there's still some room for improvement. So the first trial to really look at asymptomatic patients, because that's the vast majority of patients that I'm seeing now. The NASET trial, which was in 1991, that compared medical management with CAs, and they found that patients who were symptomatic, etc., would benefit from surgery. So there's no question. If you're symptomatic from a blockage or a narrowing in your carotid artery, treat it. But most patients are asymptomatic now, and we've been looking at. So the ACAS trial looked at asymptomatic patients comparing to best medical treatment at the time, and we found that there was a 50% risk reduction. So people that actually had a CEA, which was the gold standard at that time, there was a 50% risk reduction in strokes if you actually went in there in a patient without symptoms above 70%. Then the next trial that looked at asymptomatic patients was the ACST trial, which was the asymptomatic carotid surgery trial. And that, once we knew that there was a benefit to treating patients with asymptomatic disease, then it became a question of, do we treat them now, or do we wait a couple years, or if it gets worse or so? But ACST showed that in asymptomatic patients with above 70% stenosis, there was an improvement in the surgical arm as compared to best medical treatment if you treated them within the first couple of weeks after surgery. And now the guidelines are you want to treat them at least within a month to 3 months to get the best benefit. So we knew surgery was good, but there's shortcomings because, I mean, when I walk to the grocery store, where I live right now, a lot of people still smoke, and there's a lot of carotid disease as well. And I see patients with a big scan, and I'm like, oh, and bilateral, it's kind of one of my things. But, you know, I know they have carotids before, and, you know, it looks kind of, you know, and then there are people saying, like, you know, I had a lot of complications, so much pain from surgery, I had this big scar, etc. So then in the 1990s, we started to stent these lesions because now endovascular surgery, especially in the legs, is basically the bread and butter of most vascular surgeons. So we started to stent the carotid arteries, and then we found that the stents are just as good as a CEA. And just like these talks were speaking about, by the way, I really like this conference because in the US, we kind of pigeonhole surgery. It was good to see OBGYN and general surgery stuff. And endovascular surgery is a little different to some of these things. But CREST showed that these stents were just as good as CEA, but there were higher rates of periprocedural strokes with transfemoral stenting. So then we said, is there something better than sticking somebody's groin to go all the way up to the artery in the neck? And then in the coming years, the TCAR came about. So I won't talk about it, that's not important. So when we compare carotid endarterectomy and medical therapy, Dr. Lucas did a grand rounds a few months ago, and he did some very thought-provoking slides on it, which I reviewed. But overall, when you look at the data, the stroke risk is lower with repair, and most of these studies show that since the 1990s. So back to symptomatic patients, even if someone doesn't have symptoms and they have 50 to 69% stenosis, which is the vast majority of the patients that I see in my office, following them over the years, we found that at least 1/3 of them actually progress to 70% stenosis, and their chance of stroke is about 4% per year. So you live 10 years, you have a 40% chance of stroke. If I have 70% stenosis, I want my carotid fixed because, you know, a stroke is an instantaneous, life-altering something, okay? So multiple different disease entities are treated endovascularly, like cerebral aneurysms, coronary artery disease, thoracic aneurysms, PAD. But in contrast, carotid artery disease is largely still a surgical procedure in most cases, and there have been good reasons for that. So these are the treatment options we have, and the one I do a lot of now, I still do a lot of CEAs as well. I choose my patients very carefully, but transcarotid arterial revascularization, I think, is going to be a household name in the next 5 to 10 years or so. And the transfemoral stenting is also there. So CEAs, as I kind of alluded to, if you're symptomatic, meaning you have a stroke, or TIAs, and you have greater than 50% stenosis or arteriosclerotic plaque buildup, you should have treatment. If you're asymptomatic and you're above 70% and you're expected to live more than 5 years, you want to get your artery fixed because your risk of stroke in this time is higher than the actual surgery, the risk of having complications from surgery. So the first carotid endarterectomy was done by Michael DeBakey in 1953, and since that time, we really haven't made much headway. It's a good procedure. In experienced hands, your complication rate can be really low, but in my practice, patients always have something. It's like, if it's not the scar being too big, or there's swelling. When does the swelling go down? And when they're shaving now, they can't, go here. It's numb, etc. So that's what we saw over many years, is that not just complications, but patient complaints with the CEA scars much higher. But it has been the gold standard, because the stroke rate in experienced hands should be less than 1%. Okay, because it's a very standardized operation. You clamp each vessel and stuff like that. And once you do a good endarterectomy, your chance of a stroke should be really low. So in the 1990s, we started doing the transfemoral stenting, where you stick here and use endovascular techniques to get to the common carotid artery. But if you look here, the wire has to go all the way through the abdominal aorta into the descending thoracic aorta and then select it. I actually had a cerebral angiogram last week, and just to get into this the innominate artery was so hard. It took like 45 minutes. I'm like, man, what am I doing? But I need this lady, she couldn't get a CT angiogram. So I tend to do these. I'm not going in there blinded, because America's a different beast when it comes to complications. But anyway, my point of showing you this is, like, you have to take so many twists and turns. And even in the aortic arch, a lot of these patients have significant arteriosclerotic disease that you can knock off and cause a stroke or distal embolization in the subclavian. So then came along the transcarotid arterial vascularization, and we found that from many studies that the adverse events are really low, and the stroke rate is also exceptionally low. And interestingly, this procedure was designed for high-risk patients. Most of these initial procedures were done under local with sedation, right? And it was made for those patients who couldn't undergo general anesthesia or had an ejection fraction of 20% or something else precluding. And the stroke rate was very, very low, about 1.4%. So this was a VQI data that looked at over 10,000 patients, and they found that compared to transfemoral stenting, TCAR had a lower composite score of stroke and TIA, and when we look at death as well, it also was lower, and it was statistically significant. This one looked at irradiated necks, and we found that TCAR had a lower composite score of stroke, death, and MI as compared to CEA, which I didn't really delve into this trial very well. It was retrospective, but I'm not sure why CEA was that high, as compared to transfemoral. But as one can imagine, in an irradiated neck, the tissue just doesn't behave as a, healthy tissue planes. So TCAR kind of combines the surgical principles of neuroprotection and endovascular technology. And I think just like how general surgery is moving towards robotics and laparoscopic surgery, or most of vascular surgery is gonna at some point become minimally invasive, because it's better for the patients and the outcomes are just as good as things. And the beauty of it is you don't burn any bridges. Even with a TCAR where you make an incision in the neck, you can still go back in, and I'll speak more about that tomorrow. You can still go back in there and do a CEA outside of that surgical scar, and you can, or remove the stent and do what you have to do, okay? So it avoids the arch. The risk of cranial nerve injury is very low, because the only nerve that you're dealing with down there is the vagus nerve. When you do a CEA, you have the hypoglossal nerve, the marginal mandibular, the ansa cervicalis, etc. So, and then there's flow reversal and stenting, and the stents are just as good. So this is a quick video. I have a more detailed video tomorrow, and we can kind of just slow it down and go over the steps of the procedure, but it's a 1.36 second video. Essentially, what I like about this is that those initial trials were done on people that really had no experience with TCAR. It has a very low learning curve. It combines open surgery. You make an incision, you dissect the common carotid artery out, and you also use Seldinger technique to access the ground. Huh? Oh, oh yeah. Oh yeah, it's good. So typically the patients are placed supine. You can do it under local or general anesthesia. For the first couple, I would recommend general anesthesia. That's what I did to kind of get your bearings, etc. But you make a transverse incision, a finger breadth above the clavicle, all right? And you typically know exactly where you're gonna stick using ultrasound. So ultrasound, at least being facile with an ultrasound is good for this procedure. And typically you split the heads of the sternocleidomastoid, move the internal jugular vein, and then you have the carotid artery right there. You get control, dissect it for about 3 to 5 centimeters, and then you're golden. And this can be done at a local, because if the carotid artery is very deep, this is probably not a good candidate for a TCAR anyway. So once you get control of the common carotid artery, I typically put a purse string suture, because once you put that sheet in place to put your stent, you remove the sheet and you pull your purse string suture and you close the arteriotomy and go from there. There are a lot of steps that we'll go over, and I have some devices outside. But using Seldinger technique, we put the sheet in place, which is very short. It does not engage the carotid bifurcation, because you do not. One of the shortcomings of a transfemoral stent was that you have to put something called a spider fix device, or a neuroprotection basket, that you put above the common, the internal carotid artery, and then you start putting a stent. But as you can imagine, trying to get that device, you cause a lot of strokes, and that's what we saw. There was a high rate of stroke. So one of the key principles of this procedure is that you're not engaging the lesion. You only engage it once you actually have flow reversal. So this is what they're going to show. So now, instead of the blood going to the brain, it's actually passively. When I first saw this procedure, I thought there was a motor or something in that device. But once you clamp the common carotid artery here, the pressure gradient from the internal goes the opposite direction, and then you stick the femoral vein. So now blood is going from arterial system to a venous system, right? It's very simple. So this flow reversal now allows you to do whatever you have to, and there's a filter in the device. So any debris that is disengaged while you're stenting or ballooning goes into this device, and you don't re-engage it into the circulation. So this is essentially what it looks like. You get access to the common, you put that sheet in, connect this neuroprotection device, and then there's a sheet in the femoral vein. Typically, I do the contralateral femoral vein for ergonomics. And now once I clamp the common carotid, you'll see the blood going this way into the thing. And I just relax. Like before this point, you know, the sphincter tone is a little high. But once this is done, you do this, and you can put your balloon, if you have to balloon it multiple times, and you deploy your stent, you allow it to wash out for a few minutes, you remove your clamp, and then you're good to go. And in all the ones I've done, I haven't had a stroke. And patients are doing much better, at least from one cosmetic and symptoms after surgery. So let me just let this quickly play. So yeah, now the blood this is called flow reversal instead of a basket up in the internal carotid artery. And I can determine, so let's say a patient, we start flow reversal by clamping. I can start with low, which basically there's a channel that opens up and allows more blood to go through, versus high reversal. So if a patient becomes like confused, if you're doing it on the local with sedation, I typically have my patients squeeze a squeaky toy, and if they're getting a little confused, etc., I can toggle between high flow reversal and low flow reversal, but typically you want high flow reversal for this. And yeah, so this is what it looks like. You put that balloon, you treat the lesion, and we always put a stent in place, because there's no predicting, especially in the brain. You don't want to mess around in the brain. You can mess around in the legs if you want to, but I mean, just for context, yeah. Yeah, so then the sheet is removed, you tie a purse string, and there's a very small incision there. along Langerhans lines, and most people's, like their t-shirt can hide it. Nobody knows, all right? I know I'm making it sound very amazing, but there are some limitations. And my talk tomorrow will kind of go over that. Why is it not going? Oh, back to this. All right, I'll be quick. So that's pretty much what the setup looks like. Okay. And, TCAR has a less chance of stroke because of the things we just discussed. It also has a less chance of nerve injury because once you enter the carotid sheath, the only nerve that typically runs either between the IJ and the carotid is the vagus. Vagus is very big, and that's a key step. You have to identify it. You sweep it out of the way. You get your umbilical tape around it. You control the artery, and then clamp it. And, if you do it on the local, with sedation, less chance of an MI, smaller scar. And it's really quick. I mean, the first one took almost an hour, but now it's like 30, 35 minutes because everything is set up there. Everything is pre-planned. Once you get access, the rest is smooth sailing. So I kind of alluded to this already. Patients love it. And compared to these, you see right here, this lady has a long scar there. So you can barely see this lady's scar from a TCAR. So some clinical data. So the Roadster trial, there's a Roadster 1 and 2, and this was done in 2015 and then 2020. And this was done on high-risk surgical patients. The first Roadster was done on patients that had, it's a long list. I think it was like 20 criteria: bilateral high-grade stenosis, severe pulmonary disease, EF less than 25%. And they had a 1.4% stroke rate in the intention to treat analysis, right? But there was a lot of critics about this because most of these guys had specialized training to do this on simulators, which is kind of what I'm trying to do here. So then they did a real world trial in Roadster 2 where they just, people just had the fundamental steps of it. And they said, listen, this is the protocol, you follow it. And they had a 1.9% stroke risk. So for every 100 patients you do, less than 2 of them will get a stroke. And this was comparing CEAs and TCARs using VQI, which is a national database of real-world data. The stroke rate was equivalent. So now we started to challenge the CEA as a gold standard. All right, and it's pretty similar when you look at standard risk patients. Also Medicare data, this is unbiased data, patients that have Medicare, which is federal insurance. And they found that across the board, when you look at stroke, death, stroke/death, etc., and MI, all statistically significant, TCAR had the lowest rate as compared to transfemoral and CEAs. So, then they compared all these things as well. Neurosurgery, the beauty of this is that anyone can do it, right? And a lot of cardiologists are getting general surgeons to do the exposure, and they're starting to do it too. So if it's something that you're interested in, I think the learning curve is very low. So one would ask the question, and I actually have this discussion with my patients, there are 2 options now to treat your blockage or your narrowing. I can either go in there, scoop the plaque out, or I can put a stent. And then they're like, Doc, if this were your mom, what would you do? I'm like, I hate that question, but and now they're recommending that you have this detailed discussion with every single patient, okay? And one would beg the question, so are these stents just as good as the, going there and taking it out? And we found after the CREST trial, which was the transfemoral stenting, the patients beyond 30 days, we followed them for 10 years, and the vast majority of them, the stents are still open, above 80%, okay? And that is just in line with endarterectomies. If you ever had to do a redo endarterectomy, TCAR is a lifesaver because all that scar tissue, and then you have to find the nerves, which is thing. So I think this is where the role of this will come in. So the stents do last a very long time. It's minimally invasive, less pain. Patients can go home the same day, etc. And they, once they take their dual antiplatelet therapy, for some reason it's so close to the heart, I guess the pressure keeps them open. And this is the pitfall of the transfemoral stenting, as we alluded to, and there's several studies that also looked at these stents as well, seeing that long-term they are good. This is not important. So just quickly, I compare TCAR to endovascular abdominal aortic aneurysm repair. Before you put that patient on the table, you know exactly what size stent you're going to use because you have to measure the diameters, etc. You need to know the lesion anatomy. If it's very or circumferentially calcified, maybe not a good patient, etc. But there are some key important things. The working distance from where you access that vessel to the bifurcation here should be 5 centimeters or more as of right now, but they're working on shorter stents and sheets, etc., that may change in the future. The vessel diameter should also be greater than 6 millimeters because the actual sheet you put in there, most of these stents are about 9 millimeter stents, and you need at least a 6 French sheet in there. So the common carotid artery should be a certain diameter. It should be disease-free. That lady I did last Friday, her right side, I'm going to do a TCAR. The left side, unfortunately, I have to do a CEA because she has severe calcifications within the common carotid, so I can't clamp it. So it's good to have both options there. And ideally, the artery should be at less than 5 centimeters deep to the skin, because if it's too deep, that sheet would not be long enough. No. Oh, I live on here sometimes, but not when it comes to these things. Yeah, I typically wait 6 weeks in between. All right, yeah. And she has high grade, like 90% stenosis on both sides. It's kind of crazy, actually. And she had a cabbage, 4-vessel cabbage, less than a year ago. So, yeah, these are the patients in Montgomery, Alabama. All right, so very important. Once you put a stent in there, it's a controlled injury to the intima of the vessel. So even if a stent is in place, you need to cover the patient with dual antiplatelets. So typically, I don't look at 3 days, but this is what the company says, and the Roadster 1 and 2 were done 3 days. But I tell them 7 days. If on the morning of the procedure they make something up, oh, doc, I forgot, I cancel the procedure, unless they're symptomatic, right? And if that is the case, you can load the patient with Plavix 300 and aspirin 325 on the morning. But so far, I haven't encountered that. And that's what they're saying here. You can load the patient. Same thing with statins, typically 5 days or more. You want to start patients on that. And then post-operatively, we have to follow these stents. Stents aren't perfect, but it allows you to treat a patient for disease, just like how we do in the legs. People have narrowing in the legs. We put stents or balloons and open it up. We're just doing it in the carotid artery now. So they need to be on some type of antiplatelet therapy beyond 1 month. I drop it down from 1 antiplatelet, from 2 to 1, but I do continue statin lifelong because most of these patients have disease in other places. And specifically about a TCAR program implementation. In my institution, the rate limiting step for me was my 2 partners. They've been doing CEAs. They're like, oh, I could do one in 20 minutes, man. You young people just come and think. So once that hurdle was crossed, and in fact, I'm training them now how to do it, the financial aspect is a consideration. So in most cases, institutions, people don't go to the ICU. I send all my CEAs to the ICU because we don't have a step-down unit. But just the hospitalization would pay the cost of this procedure if you can send the patient home sooner, at least in the US. I'm not sure how it works here. But typically, once you can get approval, most surgeons will have to do a 1-day course, kind of going over the details of it. And, a rep will be there for the first 5 cases, and then they'll certify you. But I can tell you, it's not that hard. Once you can find the common carotid, you do this, the device does the rest, and if you can deploy a stent, and I have everything there, so with some stents for you guys to deploy, it's relatively easy. You get your initial consult. I always get a CTA, unless it's that lady last week. Then you make the decision. It should be shared decision making because TCAR has only been around for like 12 years or so, and it's now becoming mainstream. And most residents in the US, they probably haven't done CEAs. They do so many TCARs now that they kind of lose that surgical skill of knowing how to do a carotid endarterectomy. But we'll see how that goes. Then once you make the decision, I think patient education comes with medication compliance because you want to make sure the patients take these medications, right? When you schedule your patient preoperatively, you have to make sure you have your stent, your balloon, everything. And the beauty of it, it comes in one package. So far, there's just one company making this device, all right? And everything is in one package. If you can get it and keep it on your shelf, etc., it stays good for like 4 years or whatnot. And, you know, doing the procedure takes about 30, 45 minutes. There's some intraoperative considerations like anesthesia. As you can imagine, the carotid bulb or carotid body has the baroreceptors. So I've seen patients, just like in an open CEA, if you go dissecting around the bulb, they can become very bradycardic. Typically, you have to numb the bulb with lidocaine. Yeah, and that should address, but now you don't have that option because we're not there. So typically, the anesthesiologist will give glycopyrrolate to block the baroreceptors, and that typically corrects itself. In some patients, we're seeing hypotension postoperatively, and we think it's due to that same having a stent in the carotid artery, but that is very short limit. What's the word I'm looking for? Short term, it resolves after a few hours. So those are some of the things. And then postoperatively, I get an ultrasound at 1 month, 3 months, and then annually, and follow these patients. And so far, so good. Okay? So this is, I know it's very simplified here, but I think from my experience, it really doesn't take much to get this program up and going. And to do this case, all you need is a C-arm. You know, you don't need a fancy hybrid room, although Charles said you guys have a hybrid room. Yeah, I'm envious. I don't have one where I'm at. But yes, you just need a C-arm, and things work pretty good. So that is my introduction to TCARs.
Thank you, Dr. White-GITTENS. He came straight off of the Jumbo Jet. I don't know if you know that soca song, but we have some doubles upstairs and some other refreshments. Yeah, especially for you. I had you in mind. So please, and once you're finished, how do you feel? Meet us in the clinical skills room where we'll have some demonstrations and some laparoscopic trainers that you can play with to your heart's delight. Thank you so much. Sorry.
In terms of the self-expanding stent, is it a one-size-fits-all?
No, so on the CT scan, so they have a stents, but typically you size it. It's a tapered stent. So the proximal stent is like a 9.5 or 9.4 stent that you can put, and it deploys from proximal to distal, and then the length is also variable. The company makes the stent as well. So that comes as part of your package. No, because it's a big stent. So it's a tapered stent, and it's big in the common carotid. So the chance of that big stent migrating up is, and there's antegrade flow. So, you know, and that's why they made it a tapered stent, because if you have a single size stent, the chance of migration is pretty high. Anybody else?